Morning, everyone. Happy Friday. Let's go ahead and get started. Thanks so much for being here today. Um, so today we're going to be talking about measles, measles on the rise, regional outbreaks, epidemiology, and preparedness in HHS Region 8. So just a very quick overview about what Project ECHO is, and I will give it over to our speaker. So ECHO is a case-based virtual learning platform which connects experts and frontline teams with an all teach, all learn approach model. It matters because we want to prioritize expanding access to expertise, promoting best health practices, and reducing isolation. Led by Denver Health, and we are funded with the Robert Wood Johnson Foundation via the ECHO Institute. And we host biweekly virtual sessions from January to September of 2026. And our goal is to have outreach throughout Colorado, Utah, Montana, North Dakota, South Dakota, and Wyoming. Just a few quick disclosures. We are funded from the Administration for Strategic Preparedness and Response, or ASPR. The content of this presentation is a product of the individual presenters and does not represent the official policy of the United States government. This information is also not meant to be a substitute for professional medical advice, diagnosis, and treatment. All right, with that, I'd like to introduce our speaker, Leslie Warren. She's an epidemiology unit supervisor with the Denver Department of Public Health and Environment, or DDPHE. In her role there, Leslie supports a team of 3 epidemiologists specializing in communicable disease surveillance, outbreak management, data analysis, and partnership building. Prior to DDPHE, Leslie spent 5 years as a communicable disease epidemiologist at the former Tri-County Health Department. She's proud to work with public health practitioners and clinicians from all backgrounds who bring so much enthusiasm, dedication, and resilience for addressing public health in Colorado. Outside of work, Leslie enjoys spending time with her dog, Otto, climbing, and playing pickleball. It says poorly, but I'm going to say it's probably better than I can. So with that, I am going to hand it over to Leslie. Leslie, thanks so much for being here.
Thanks, Ariana. Okay, I will start sharing. Okay. So in the right mode. Does this still look all right?
Yes, that looks great.
Okay. All right. Well, perfect. Well, thanks everyone for being here on a kind of a chilly Friday morning. My name is Leslie, as Ariana said, and I currently work at the Denver Department of Public Health and Environment. I support our epidemiology unit. And today I'll be kind of sharing the kind of perspectives and impacts of local measles response. So just our quick objectives, I'll run through just to kind of set the stage, hoping to really describe the mindset and the process of managing measles responses from the perspective of a larger metropolitan local public health agency that I often refer to as an LPHA, to highlight our unique challenges and considerations when responding to measles in Denver County, kind of discuss an LPHA's short-term and long-term implications of losing our measles-free status in the country, and would love to also gather feedback and insight from our clinical partners, EM, and public health practitioners through some discussion questions I've tried to weave throughout the presentation as we go. If you have any questions for me, please, along the way, please shout them out or put in the chat. I mean, really anything goes. It's kind of just a free-for-all. So let's get into it. Agenda-wise, really briefly, what we're going to be covering: an intro to the public health landscape for our Denver County, what our communicable disease response looks like in Denver, our Denver Department of Public Health and Environment, and then really breaking down our Denver measles response into a pre, a peri, and a post phase. And then I'll wrap up just with some implications, some perspectives, and obvious, these lessons that we are continuing to learn along the way. So for those who maybe are not in Colorado or Denver, welcome to Denver County. We are centrally located in the Denver metro area. We're surrounded by our friends in Adams, Arapahoe, Douglas, Boulder, Broomfield, and Jefferson counties. In Denver, I just looked at a quick estimate recently, was about 729,000 that we serve. predominantly non-Hispanic white, but closely followed behind, well, sort of closely followed behind our Hispanic race and ethnicity at 27.4%. In Denver County, we have 78 statistical neighborhoods that each are very unique, have like their own, really interesting features. I always like to put the plug in. In Denver, we always have exciting, fun things going on. We're home to 4 of our major league or pro sports teams that play at Ball Arena, our Empower Field, Coors Field. We have the convention center here right near our office. We always have large events. So every year, you might have heard January's National Western Stock Show that wraps up. We have 2 pretty large university campuses in Denver. And of course, we can't forget we have Denver International Airport within our jurisdiction as well. So in addition to the kind of exciting features of Denver, I think in a very real sense, Denver has a complex landscape as a larger city. We contain 5 large hospital systems in our county that we work to coordinate with here at the health department. And in particular, Denver Health being our large safety net hospital that's right down the road from us. We also have a large population of unhoused individuals and also a large landscape of homeless service providers and shelters and resources. I think many of you might be very familiar with the All in Mile High program, which is a multi-year initiative led by our Mayor Mike Johnson to eliminate unsheltered houselessness during his years. Along with that, there are plenty of additional projects and initiatives within that. So like House 1000, there's Road to Recovery, and these are very large citywide efforts that touch virtually every department within the city and many, many external partners. You may have also been familiar with or impacted by the 2023 to 2024 migrant crisis that Denver was heavily involved with, along with our community partners. And, like many fast-growing cities, Denver is not, also grapples with a lot of those same challenges of, affordable housing, food access, environmental justice, and a lot of the historic geographic, racial, and socioeconomic inequities that have really been very present in Denver, which is often depicted, as you might have seen, it's called the inverted L, where we see our neighborhoods kind of within the borders of our Denver County tend to have, lower socioeconomic status, higher on the social vulnerability index. So something that we're very, very cognizant of in public health. So for Denver Department of Public Health and Environment, we comprise of 8 divisions. Our program in particular sits within our Shared Services and Business Operations division. We are housed within our Epidemiology and Data Science team, who's led by our program manager, Lizzie Friend. And then within that, we have 3 units. We have our Data Science unit, we have our Disease Intervention unit, which includes 4 disease intervention specialists and their supervisor, Grace Nelson. And then myself and my team sit under our Epidemiology unit. For measles and these very large responses, we partner incredibly closely with our Emergency Management and Medical Operations Division, also known as EMO, as you might hear me refer to it. And they have 2 programs, Emergency Management and Public Health Nursing. I imagine most of us are fairly familiar with just communicable disease reporting and then general flow. So I'll broadly touch upon this infographic just to explain how Denver Department of Public Health and Environment kind of fits within this and manages communicable disease cases. So top infographic is very standard. Individual who's ill enough to seek medical care, submit a sample, whether it could be stool, blood, NP, we've heard of it all. They get tested. When they test positive for any of the many reportable conditions, their sample is submitted to the state, or their results are submitted to the state health department, Colorado Department of Public Health and Environment. And based on the county of residence for that patient, it's then divvied out to the individual jurisdictions. So Denver County residents, when they land on our doorstep, our disease intervention specialists are kind of the frontline public health, first contact probably for many of these patients. Our disease intervention team, DIS, are reaching out individually to every single case that gets reported to Denver County. They're on the phone conducting interviews, they're doing med record lookups, learning really the nitty-gritty details of this person's illness, exposures, risks of ongoing transmission. And then they're also implementing control measures as needed. They're providing education, guidance, and resources. If for some reason these cases start to cluster in any way or become an outbreak, our epidemiology team supports all outbreak investigations and management. Sometimes as we see it with measles, even if it's not a full outbreak, but a single case can often spark a full large scale activation where it's kind of all hands on deck between our teams. And we then collaborate with our EMO division to do all the countermeasures and all the planning and preparedness. So whether that is with our nursing team, administering immunizations, post-exposure prophylaxis, applying quarantine, isolation orders, it's very much a team setup. And then at the very end of all of these activations, we take a moment to reflect, whether that's very formal hot wash style or, just let's talk about what worked well, what we want to improve on in the future. So for the purposes of this presentation, I've tried to break it into three buckets: the pre, peri, and post phases. Pre being our planning, preparation, and early response. The activation is our peri, kind of we're in the thick of it, and then post being our results when we deactivated and some of our reflections. I imagine that many of us are also quite familiar with the nuts and bolts of measles as a disease, what the general case investigation process and what contact tracing probably looks like. So for the purposes of this presentation, my goal is to focus on aspects of the response that might be unique or characteristic to responding at the local level, and maybe some features of our Denver response in particular. Again, please stop me along the way. We'll have some breaks for discussion questions as well. Oh, and I put the arrow in to always say, this is a cyclical process. I don't do, emergency management, but the planning P is somewhere in there. So shout out to our emergency management teams. I just don't know anything about it. All right. So to kick us off for our pre-planning stage, I wanted to highlight what we were doing for internal readiness, like where we were at. This was specifically very multidisciplinary preparedness efforts between our epidemiology, our disease intervention teams, emergency management, and nursing. We're just trying to cover our bases and think proactively how to put ourselves and our partners in the best position for these impending measles cases. The first thing we did was to try to engage with our Denver City Council members and leadership very early on in the game. Our nursing program manager, Kristen Shu, sat down and presented to our city council to really kind of set the stage for what could be the impacts to Denver County, both from an immunization and prevention side, but also to a reactionary response. This is what's going to happen. I think it was really successful in garnering their support, their understanding, and it really just created and forged this connection point, not only for measles, but for other responses to come in the future. We did a lot of early coordination with our surrounding LPHA partners that we work incredibly closely with, and the state health department, CDPHE. We were solidifying these mutual aid agreements. We were trying to put out unified communication and messaging to our communities, and building just a lot of protocols for PEP needs, supporting PEP needs across the region, transferring IG, all of those considerations. Prior to this past year, measles was definitely a rarity for us. So I think for many of us, this was our first go around with investigating measles. And for others of us it had probably been years and we were all potentially very rusty. So we really wanted to prioritize internal team trainings, making sure our teams were ready for how to conduct the full case investigations, feeling confident with rule out investigations, and how to do the contact tracing when the time came. We also took some time to do some capacity evaluation. So again, very collaborative between our three programs, sitting down to talk about what does field testing actually look like for suspected cases? What does mobile PEP administration look like? And that handoff and referral process. When the time comes, how are we going to prioritize and offboard our routine work? What is our staffing availability? And I think the trickiest aspect, for me at least, is trying to think through how and when we start pulling in other team members into these early phases, really, balancing how team members can support these efforts and how we lean on their amazing relationships and skills that they've built with these partners, but also trying to be cognizant that early burnout is very it can happen. And we've seen it multiple times over with COVID. So partner outreach, one of our biggest priority areas early on was to meet with our community partners who we sat down and we're thinking through who might be more heavily impacted by measles responses, or which partners are serving clientele that tend to be more disproportionately affected by measles. Our general strategy in meeting with these different partners was to describe our role as public health in managing measles, help them kind of estimate what the impact might be to their communities, strategize preparedness steps, and ultimately offer the building of tailored protocols, communications plans between DDPHE and our partners, just again, forming that connection early on. As mentioned earlier, we have 5 pretty large hospital systems in the city and county of Denver. So in meeting with some of our hospital partners, the goal was to streamline that communication really early, help make sure they were all set up and they knew how to submit samples to the state health department for quicker turnaround times, walk through potentially protocols for screening or triaging, getting patients through the ED waiting rooms as quickly as possible into those negative pressure rooms, mitigate risk to others. And then just some other considerations, talking through and explaining, hey, when public health gets these folks on the phone, this is what we're typically asking to help get the ball rolling for our investigations. And a big one, actually, an interesting one, was recommending and seeing how hospital systems work with their IT departments to explore what information could be queried or what reports can be pre-built in case the day comes where we need to pull pretty big ED contact lists. But that is hospital partners. Also, we met with a couple of our larger university campuses, kind of similar to our hospital partners. We met with their medical directors and their emergency management staff, really, again, to lay out and say, hey, this is who we are. Make sure you have the resources and what you need when you might have to evaluate a staff member or a student with symptoms. You can always reach us. And just, again, thinking through the impacts potentially of a case on campus. Also mentioned before, we have a pretty unique and complex sheltering and shelter provider landscape. One of our epidemiologists, Alakina, and our team her work kind of specializes in working with these service providers. So she's built so many amazing relationships with them previously, where she kind of is a one-stop shop for the executive directors who have questions or staff. They always know they can come to Ella, and she can consult. She can provide tailored guidance. She can do on-site walkthroughs, and that's just been such a valuable connection point to ensure hopefully they have everything they need. And then I don't want to forget our biggest partner probably is that unfortunately in Denver, we have a single school district, albeit a very large and diverse district, but just one. Denver Public Schools, our epidemiology and nursing program, we meet with them monthly. So that is a huge relationship that's been built. And over time, it's really made these challenging scenarios a lot easier to be in communication with them. So again, early on, we were working with them. We were working with the school-based health clinics who are operated by Denver Health providers to really just sit down and coordinate, build out a protocol, build out our chain of communication, and help provide some nurses with guidance if there were to be a student or staff who walks in with a rash of concern. We also put out a lot of communications to families and the community within the public health school system. And I didn't map them out because actually I don't know where they're all located, but we do have a fairly large network of childcares, private or tied to the district, and early childhood education centers, which similarly protocols would have looked a lot similar. Before we move on, I wanted to just put a plug in that we actually had a lot of early response practice. So as these preparedness things were happening, while we didn't receive our first measles case until early April, our teams were very well practiced in responding to measles related exposures and then doing their assessments. The first one is, which many of you are probably very familiar with, the CDC and the state health department. Whenever they have a traveler exposed to someone with measles on a flight, they will send that information and the locals conduct that follow-up with those travelers. This is just a fake example. I promise there's no PHI in here, but this is kind of just an example of the notices we might get. We were at this time already receiving a pretty steady stream of notifications of measles cases who are traveling through the Denver International Airport during their infectious period. So we were really fortunate to leverage the existing relationship that we had with DEN and their emergency management teams to our emergency management teams to quickly assess and respond to these. You know, they were contacting them immediately. We were helping dig up flight information, gate information, baggage claim carousel information. We were doing a lot of web sleuthing and just figuring out what key information we needed to be able to communicate that out to the public so they could assess and for their own risk. This happened through collaborative press releases with the state health department, health alert network notifications, web pages, social media. And you know, we saw, I think it's interesting. We kind of see a range of travelers through the airport. So we see some where they have a 30-minute layover, just enough time to run from one gate to another. And then you have travelers who are here for an overnight layover, and that we see the whole spectrum. So this is just an example of what we are doing when we're evaluating and assessing step by step of what the traveler is doing from the time they entered the airport to the time they leave for their destination. And this is actually just a screen grab from the state's website from an exposure of one of our pretty extensive exposures of an out-of-state traveler who came into the airport, stayed overnight. So there was a shuttle involved, there was a hotel involved, it was back to the airport, and they left the next day. And then the last one, I wanted to put a plug in as well for our teams that naturally, as news of measles activity started to circulate, there was a steep influx of patients being evaluated for symptoms and tested. By early 2025, our teams, we were receiving 4 to 5 suspected cases, probably per day. So our teams were well versed in evaluating these suspected cases, conducting the full case investigations, and really preparing that any of these could have popped up positive at any time. Oh, our first round of discussion questions. These I'll actually, I have some after each section, but ultimately also I will recap these at the very end. So if nothing sparks idea now, but you want to revisit it, we absolutely can. But for the first ones, I just wanted to highlight a couple that came to mind and would love any feedback is who are the high priority populations in your jurisdiction? And if you have any ideas or methods that you found successful in connecting and preparing these populations, we'd love to hear about it. Second one, maybe a little bit tailored to our clinicians on the call. We're always wondering what can public health practitioners do to be a better partner to healthcare providers who are seeing these patients and evaluating them, and what has worked to streamline communication or collaboration. So I know those are two big questions. Maybe I'll give it a couple minutes. If anyone wants to hop on and share, would love to hear it. Also, or feel free to put in the chat. I can monitor those as well. Maybe I'll give it a minute. I have no problem sitting in silence. I'll give it a good minute, but please pop on if you want.
Hi. Oh, should I raise my hand? Sorry.
Oh, hey, Jillian. Yeah, no, get
Hey.
in.
Oh,
Yeah,
sorry.
jump
Hey.
in.
Um, well, my jurisdiction is Denver, but I think kind of a difficult to reach, vulnerable group we ran into are people without transportation needs, people with limited access to healthcare. So that was, I don't know what other jurisdictions found in success when helping people with those types of needs, but that was just like a high priority population we continue to brainstorm around and supporting during testing, evaluation, treatment, like whatever that looks like. But transportation and healthcare access.
Awesome. Thanks, Jillian. That's a perfect example. Thank you. Thank you. All right. Well, interesting. I'll keep plugging away, but again, just keep chewing on these, and we'll revisit it. And if you have any thoughts as we continue on. Well, I mean, I'm jumping right back in, and speed ahead in time a little bit, and it's April, and we finally get our first official Denver case. So we received this call on Sunday, April 6th, from an ED provider notifying of a symptomatic unvaccinated infant with recent travel. They collected the NP swab on site, which was amazing. They let us know, and we followed up with the family on Sunday afternoon. We learned that the patient had developed upper respiratory symptoms on April 4th, and then a tactile fever. Mother of the case had thought the rash started on the abdomen the evening of 4/5, and then by the time they were in the emergency department on the Sunday, the 6th, it spread across the body. While symptoms were mostly consistent, and what really caught our attention was that the family had recently returned from a trip to Mexico on the 30th of March. They were visiting a family in a city that had recently been experiencing a pretty rampant outbreak of measles. So our little flags were raised. We actually notified the state health department of the incoming specimen and asked them to flag it for testing first thing on Monday morning. So a huge thank you to actually our state partners for being so responsive and being able to push that through. We did, in fact, Monday at 12:30 p.m., we got the PCR positive results. We notified the family, finished up the case investigation, and we referred 4 of the household contacts for titer testing. And that same day, we received the full ED contact list at 8 p.m. that night, so we could be ready to roll for the next day. Kind of interesting, 2 of the 4 household contacts after their titers were tested had positive titers. 1 was equivocal and 1 was negative. So the equivocal and negative household contacts were both quarantined. Fortunately, honestly, thanks in huge part to the provider who called us so early to notify. We were fortunate. We had a bit of lag time to start the assessments, the contact tracing assessments, and we had about a 2.5-day window for MMR PEP, and then a longer window for finishing up IG PEP, which was huge. Interestingly, with this case, 12 days into the household contacts, the negative household contacts quarantine, they did develop a rash on their hairline and it descended down their bodies. So our DDPHE nursing team actually went out did a home visit to collect a swab, and that household contact did come back PCR positive. Fortunately, because they were quarantined and they were being actively monitored, there were no healthcare exposures and no community exposures. So all that to say, quarantine does work when you have the ability to implement it and conduct active daily monitoring. And also, I'd be remiss to say, like, this family was like absolutely lovely to work with. So honestly, it could have been a lot worse. So in 2025, we had 4 cases in Denver County residents, which honestly pales in comparison to some of our surrounding partners and some of our other agency friends. But to briefly recap, we had like I said, the 1 unvaccinated infant that I just reviewed, followed by their household contact, which was a secondary case. We had actually very shortly after a very well vaccinated adult. I think they had like three MMRs on board. Interestingly, who had also just returned from a trip to Mexico to the same city as the other family, unrelated though. Very mild symptoms and no community exposures. And then the 4th Denver case was also a vaccinated adult associated with the airline outbreak I'll talk about, who had very mild symptoms and was actually tested retrospectively as part of this kind of cleanup of flight contacts. And I also just wanted to briefly highlight some of the numbers from this infant's 1 visit to the hospital ED. So again, they were at the ED on Sunday the 6th from 10:30 a.m. to 2:35 p.m. 4 hours, and that actually resulted in 250 emergency department high-risk contacts. That does not include staff, and 150 of those were Denver County residents that we did the contact tracing for. Besides our own 4 Denver County residents, between April and May, our agency was constantly responding to and supporting contact investigations for out-of-county cases who either had exposures in Denver County, or we had Denver County residents who were exposed to those cases through a variety of means. So as mentioned earlier in the presentation, Denver, we're centrally located, always stuff happening. So we had some very interesting high-risk workplace exposures, business exposures, hotel stays, recreational settings, yoga classes, you name it. And we definitely were dabbling and digging into those. We also had a very interesting outbreak associated with an airline traveler who flew into Denver International Airport. They had an overnight stay and then they flew out the next day. That very ill traveler resulted in 9 additional Colorado measles cases and 7 out-of-state cases. So, shameless plug, State Health Department, they just put out an MMWR kind of recounting that large airline outbreak. So you can find it in the MMWR weekly report if you're bored. And then also during this time, as always, our nursing programs remained incredibly busy throughout this whole period, continuously deploying staff into the field for testing, providing PEP administration in the field, but also standing up clinics at our own offices or public spaces, and as well as coordinating with our partners at the Public Health Institute of Denver Health to refer individuals for PEP after a pretty large ED exposure. So, and then, of course, a piece I'll touch on a little bit later is the titer testing. We were doing quarantine orders, we were doing isolation orders, and just the other things we need to do to ensure we didn't have those secondary cases. Okay. So just to kind of highlight, our primary response again was between April through August, and this time frame was both a total blur in time, but it was also the longest spring and summer of our entire lives, probably. So I definitely look forward to circling back on this a bit at the end, but I want to highlight that this is, I think, a very tangible piece of what it's like for responding to these big incidents at the local level. It is both, it's like all consuming and it goes so fast, but also, 4 months out of a year for dedicating completely to measles is kind of a long time for a local agency. As soon as that initial case came through, we had immediate activation of our Department Operations Center. We transitioned basically our full teams to, data intervention, that's supposed to be disease intervention, our teams to measles response, along with our nursing and emergency management groups. And on paper, our teams, like the numbers, we include 7 Epi and DIS staff and our 2 supervisors and our manager. I think day in, day out, those numbers look good, that we're well staffed. But one thing I always like to point out is that our staff are, we are generalist epidemiologists and we are generalist disease intervention specialists. So we're managing the diseases for across the board, whether it's zoonotic, vaccine preventable, enteric, all outbreaks. And so it can be it can be different and all consuming to switch over to fully measles activation. And I think that's one of our characteristics of being at the local level is we just have a lot of generalists that have to cover the whole gamut. But fortunately, our state health department was a really great partner. They supported our routine case investigations for a while so we could respond to measles. We had nursing and emergency service worker staff from DDPHE step in to help do surge support for some of our case or contact investigations. And fortunately, it just so happened that during that time, the schools are winding down for the summer. Outbreaks are usually down. So we kind of might have gotten a natural break from some other things going on. I want to point out always, we have as I mentioned before, our very small and nimble nursing team is like such a benefit. They are a small but mighty team, and they're always out in the community. We also did a lot of effort. We had a lot of efforts between LPHAs and CDPHE, trying as best as we could to standardize all of our risk assessments, to conduct when we're doing immunity criteria checks, to make sure we're trying to be as equitable as possible across our region, but we're providing similar public health guidance and interventions and control measures, and really offer each other support across county lines. If one of us had a very large contact investigation, some of us could actually volunteer staff to go support theirs. So it's completely collaborative. I think we really work hard to evolve cohesively together as much as possible, even when we know our counties might look a little different capacity wise. Ultimately, we had a lot of success in leveraging those relationships. We had channels for epi to epi, nursing to nursing, EPR to EPR, and I think that's a strength of Colorado is our LPHAs work really, really well together. So let's plug. Before I move on to this next section, I want to again highlight just a couple of the cool things that our Denver County team did to help manage these outbreaks. Our program manager, Lizzie, created a more real-time dashboard for tracking the progress of our contact investigations so you could kind of see our metrics and how they changed over time. She also created a referral form and a similar dashboard for PEP referrals. So kind of managing those handoff of PEP referrals back and forth between our EPI and DIS teams and our nursing program who are actually doing the administration. And, we were just trying to get creative on how we work within the bounds of our state surveillance system as well, which is EpiTrax. It's great, but there is a lot, there's some natural, manual data entry, duplicate data entry. So just trying to figure out how to optimize ourselves while working in this larger system. I also wanted to finally touch upon our public health orders, which, I know is not, it's kind of a Denver thing in many ways. But we use a lot of public health orders for these large situations, for these large responses, for outbreaks, exclusions. And the way I like to classify it is really anytime that we as public health are asking an individual or a facility to go above and beyond what they normally would be doing, we like to put it in writing in a public health order. I know a lot of jurisdictions aren't able to do this or don't use public health orders very often, but it's just something that we've used. And I think in this circumstance for measles, we were providing public health orders to every single person that we quarantined, isolated, or excluded from high-risk settings. And we actually had DDPHE staff who would drive out to their houses and hand deliver these public health orders. So I think that kind of helped with the continuity of communications. I think it helped with compliance. But again, knowing that's not a standard thing across all the LPHAs. All right, second set, to put everyone on the spot again, another set of discussion questions to kind of chew on was how does PEP administration and immunoglobulin management work in your regions? What protocols have you worked out to help coordinate PEP administration and IG transfer? And different flavor, I'd love to hear if anyone has insights about your challenges or innovations surrounding management of measles data. So again, I'll put a pause, I'll mute myself, and we'll sit here together for a minute or two and think, and then please, unmute and just jump in there if you have ideas. See a chat. Oh, yes. Thank you, Jillian. That's your tee. Yeah, that's a perfect tee up to we'll be talking about next. Thank you. All right. Well, same deal. Think about it. We'll revisit these and keep the ideas coming. And as I move us into actually our final post outbreak phase to kind of wrap things up. So to kick off this section, I just want to present some final numbers from our I would call it our 4.5 intensive phase months. We individually conducted 520 contact investigations for individuals who were determined to have high or medium risk exposures. We recommended and administered PEP to 51 contacts, 9 of those being immunoglobulin, 42 being MMR. We ended up quarantining 9 contacts and excluding 11 additional contacts from high risk settings for their incubation period. And I think our biggest win is just to highlight that besides the household contact that was a secondary case, we didn't have any other secondary cases that we know of from our cases or our contacts. Don't quote me, actually, that's too soon. Don't quote me, but I think we deactivated our doc in July, but our emergency management friends, if you're on, please pop it in the chat if I messed up those dates. But we deactivated once we felt we were in a fairly confident place where the large responses had mostly wrapped up, and we were just kind of doing once every so often contact investigation for other Colorado cases as needed. So really, once we deactivated, we transitioned back to routine work, finishing up the last push of our summer enterics and zoonotic season, and gearing up for the school year and gearing up for outbreak season in the fall. We were building in a lot of admin days for our teams to try to catch up on data entry, data QA, data cleanup along the way. And when we were also trying to make a concerted effort to do our own larger, summarization of findings, what is our metrics, and reviewing our processes that worked well and what didn't go well. We spent, I'd say, a fair amount of time ideating on building out a more sustainable or modern system for data collection. I always like to point to this is the plight of local public health, is the shared spreadsheet. I think in local public health, we hear a lot about data modernization these days, integrated data systems, APIs, automation, data lake houses, and feeling that urgency to feel like we need to be part of this. But ultimately, sometimes in these responses, it's not always glamorous. And a shared spreadsheet, it gets the job done, it gets contacts and cases triaged out, and that is what we do. Fortunately, our program manager, Lizzie, and our data science team are really leading the way to help guide those efforts to bring us into the modern world and the modern age of data, while also understanding kind of the functionality and operation that we need to do these responses. Not as fun, but one thing we really took a step back is to assess our team morale and burnout, while also preparing that this could happen again at any time. I don't think it's any surprise to anyone on this call. This was all happening with, in the landscape of the administration change and federal cuts. And you might be aware that city and county was also kind of navigating some really serious budget shortfall. So that resulted in a lot of uncertainty to funding and staffing at DDPHE. And it was just a taxing time for everyone. Our agency is an office or a department under the mayor. So we really feel any changes within kind of the mayoral landscape as well. And then in the post-outbreak stages, our aims were to, number one, re-engage partners that we had maybe connected with a while back, but wanted to update, and we felt like we needed to reconnect. And then moving forward, we also wanted to engage with partners that we hadn't captured in that first go around, and really figure out what gaps who we weren't talking to and who we should be talking to moving forward. Then, as Jillian kind of mentioned, one of our biggest gaps is that we realize we really need a formal surge team or surge capacity within our agency. So we are continuing to actually work closely with our emergency management and nursing programs to set up a surge team. So we have our scope of work ready. We did a pilot orientation. We have our workflows. And now we're starting to reach out to other divisions and programs to start to kind of gain interest to see who might want to join our surge program. All right, we're getting there. Thank you for bearing with me. As we wrap up, I just want to take a second to talk about local implications. I think there are so many dimensions working in local public health. I've worked in local public health for just under 10 years now, and I'm like constantly learning and evolving. And I think the biggest aspect to me is that measles has a huge impact on local public health. It had a huge impact years ago when we were doing one international travel associated case once every 3 years. And it was like, everything stops and we have to respond. And now we're in a very different landscape. And the impact, I think, has exponentially grown since then. Even as a large LPHA here at Denver, with good ties and support from our city government, from our partnering agencies, our state health department, from our community partners, measles really pushed us to the max this time around. Everyone was giving 110% of themselves, going above and beyond, supporting the work we were doing, supporting team members, supporting the community. And I could not be prouder to work on this team. There were like a lot of dicey moments though. And I really also can't emphasize enough how when you work at the local public health level, you feel like any undulation or any fluctuation in things happening around you, whether that's in your agency or just in your community. We're super front facing. So we, I think, really feel that even the smallest changes of funding, staffing, if city initiatives change, if policy changes, it has this incredible ripple effect. And then suddenly with a large response, it becomes like all consuming. So that's my plug. But ultimately, coming out of 2025, we had a really I would say, an interesting opportunity to take like a critical look on how we managed responses in the past and what we have to do now moving into the future. The ones I'm going to highlight here, these are just from my own mind, and so I know I'm missing many of them, and there's many other brains smarter than myself who probably have even better insight. But these are just the big ones for me. I think in an interesting way, we almost were reintroduced to our own jurisdiction, working through the lens of measles investigations. Our county lines in the Denver metro area, they're squiggly, they're arbitrary, but there are, even though we are intermixing between jurisdictions, each jurisdiction actually really does have their own unique challenges and advantages. Our particular communities in Denver County, our populations, our environmental factors, our economic factors, and our social factors can look very different even to our neighboring counties in like Adams or Douglas County. But we also have a lot of advantages. I think if you were to look at our recent cases, 3 of the 4 cases were exposed or associated with the outbreak in Mexico. At the beginning of this, we were just ready for the influx to be from the Texas and the New Mexico outbreaks. But ultimately, we didn't actually end up having any contact or any cases. And I don't think we actually had many contacts as a result of those outbreaks. And knock on wood, we haven't had any cases or contacts from our New Mexico or the Arizona or Utah outbreaks either. So I think in Denver, other thing we have to think about is that we have pretty overall good MMR coverage. It's not perfect, but we're in a better place than a lot of jurisdictions. And we don't have as many pockets of undervaccinated or unvaccinated groups as some other highly affected communities. So if you look at it kind of holistically, the risk of sustained community transmission tends to be I think we're a little bit more insulated than other jurisdictions. I think this lent itself to really, for us moving forward, to really lean into the understanding of and the epidemiology of our cases and the cases being reported around us, and use that epidemiology to guide how we're making these decisions. As I mentioned before, we're generalists, kind of covering a lot of different disease things. So we don't always have the capacity or luxury to just be on high alert for measles 100% of the time. We take what's happening at the national level. We take the updates from the state health department. We look contextually at what's happening with our cases, and that is what's been driving our decision making here at the local level. Other thing I talk about is that I think many of us, we love being by the book. We love a good manual. We want a nice process that ensures that we're doing the most thorough work we can. But we had to take a very realistic approach to how we respond to measles. And I know not all of us love it, but I think local public health, we are very good at working in the gray area, balancing what is the actual risk to what is our capacity to we have to make a decision, and we have to prioritize, and we have to do something that's actionable that we can stand by. I'll throw out an example. This is like something that's very common when we talk about measles, is assessing immunity status for contacts. You might read in a manual that has to be 1 documented dose of MMR, but when we're sitting with a list of hundreds of contacts, are we really going to quarantine a contact who grew up in a different state, went through the public school system, went to a university, works a remote job, and knows they were vaccinated just because they're not in our Colorado immunization system? So we have to make that decision. That might not align perfectly, but it's a decision that we make the judgment call here at the local level, and we stand by it, and we work within the gray. I think that really rolls into, I'll wrap up quickly, but I think that really rolls into this leadership term from Kouzes and Posner, which is to challenge the process. And I think we tried to do that and experiment that with our partners. So one example I'll pull from is that we did a great walkthrough of an emergency department with one of our bigger hospital partners to really understand their air exchange and air handling system. So to challenging the standard 2-hour hang time in the air, to see if we can refine our processes to actually use science to drive maybe the prioritization of certain ED contacts over others and look at that risk. So that was really cool. Last one's quick is just this really gave us an opportunity to look at DDPHE and some of the gaps at a systems level, things that have been around forever, and we just don't see the impact until things like this happen. One of them is, some of our staff on our team are hourly and some of them are salaried. And when you look at measles, we're all basically doing the exact same function to make this happen, but it really affects our who can we staff overtime, who can we staff over the weekends, who can we staff after hours, and it puts boundaries on staff who would want to help support but are maybe have their hands tied because they can't log hours. So just silly like inequities that really come to light when we're responding at the local level. And then ultimately, my last plug is for, I think, the outlook of measles in this world where we have more endemic measles. It's a huge lift on our emergency management and our nursing programs, who now are leading efforts in prevention and the preparedness space that's going to look so much different than it used to. Our EPI and DIS teams, we're used to reactionary work. So we're used to staffing up and getting ready and responding to things to mitigate once it already happens. But I think with the landscape of measles, it just puts so much more pressure on those teams who are out there doing the preventative work. And I think that's one of the big takeaways that I've learned, at least from our local perspective. Okay, perfect. I think, again, I don't want to overwhelm anyone, but the last kind of small set of discussion questions I thought of were, what does surge capacity look like for your own agencies or your own programs? And maybe how have your jurisdictions challenged the process along the way? So noodle on those. I'm going to flip it to just the review of our fuller discussion questions. If anyone has any thoughts, please jump into those. If you have any quick questions for me before I hand it back to Ariana. Oh, Jacob, yeah, thanks.
Hi, Leslie. Yeah, thank you so much for this presentation. This was really insightful, really informative. And let me also just talk about, we always hear when public health is one of those fields where when it works well, people often don't know what's happening, and talk about the perfect example of this. Like, we work in this space at the Regional Treatment Center. And we were aware of kind of the situation with measles in Denver last year, but I personally had no idea just how much work was going into this behind the scenes. So thank you for that. And thank you to your team for all of your incredible work. Um, I think my question is maybe related to your question about surge capacity. And this is something too that I think a lot of us on the call who work in any kind of preparedness and response space are familiar with. Something happens and then everybody has to kind of drop everything else that they're doing to focus on that one very prescient issue. So it's similar for us here at Denver Health. And we have a whole system, and I won't speak to it because I know there's others on our call who have better insight into like how we backfill staffing and pull up staff who are trained to support response. But I think my question for you was really around just the human impact of all this. And I know you talked about your approach to staffing and just again the effort that went into it on the part of everybody. So maybe from an individual perspective, but also from a system perspective, like what are some of the strategies, if you could talk more about, that you use when you do have people who are, working long days, overtime, evenings, like, and especially for a response that's going to take weeks or months, how do you help everybody feel safe and protected and take care of your staff through all that?
Thanks, Jacob. That's such a great question and a great timing. We were talking about this yesterday with our LPHA managers, with Grace and I were on a call with them. So Julian, maybe let me give you the floor first if you have a response to Jacob before I jump back in.
I was just going to throw out Jacob because Leslie is my supervisor and she was holding our team together. And I think you're maybe talking about the idea of morale and like keeping in it. And, you know, we're coming out of COVID. So that post pandemic, we were getting that COVID fatigue. But I just want to throw out that Grace and Leslie and Lizzie are kind of fearless leaders, as well as our EPR team, like so supportive. They were always there to listen, and I will say that they would jump in and take like a bunch of work to give us a break. So I don't know. I think we just are building a great relationship as a team with DIS and EPI. Not to say we didn't get annoyed with each other at any time or frustrated or tired, but I just wanted to throw out that they did an amazing job of leading the teams through it and keeping and making sure that we were taking care of ourselves and being really, really thoughtful about that.
Thanks, Julian. Well, okay. Well, maybe I'll give, and then Grace and Paul and Emily, please jump in. Anyone, honestly, this is from my small window. We did a lot of things, I think, unofficially, which we would try to flex people's time if it was just like too much. You know, when we said, "Hey, I know I can't pay you more for these hours, but I know you've been working them, and I need you to. Why don't you need to take a half day because I know you've been logging these over the weekend or after when you should be logging hours." Um, so that was kind of that worked a little bit, but I think that does bring up a gap, Jacob, that is that I don't, well, maybe I'm just not aware or I'm not good at reading policies, but I don't think we have a set policy for when you've maxed out or you've gone 10 hours overtime or 8 hours, what as an agency, what does that look like? And again, we try to do an adjustment on the fly of just recognizing we need to give time back where we can, give people brain breaks. At a certain point, I think we stopped. We were staffing in the 7 day a week coverage for the weekends, but I think eventually we even said, no, we're not going to do this. And if we have stuff that happens over the weekend, we will do what we can, but we're going to have our teams back on Monday, and that's when we'll respond. So there is always adjustment. We try to give our teams some admin time of just like, hey, I know we have outbreaks that are probably going to come through. Don't worry about them. I think you need to just sit down and free yourself of like the 800 data cleanup things you need to do. And then what do we do? We probably cried a lot. I don't know. Sat our cubes together, cried, and we had a lot of team meetings together. But I don't, gosh, I don't want to put Grace or Paul on the spot, but please jump in because I think all of us were kind of experimenting along the way.
I think you mentioned what I was going to add, Leslie, that, throughout the process, we realized like documentation would get really backed up because we were, our priority was first to get folks on the phone when we were doing contact tracing. And so we further along in the response kind of created a schedule where people had like no new contact days and they had days to catch up on their paperwork because I think that was just stressful to have those things pile up too. And then I know Leslie and Lizzie tried to bring in food, some things for us when we were in the office in those early days that just help with camaraderie. And our, weekly, daily calls with the EPR team and the nursing team were really helpful too, just to like hash out problems as they came up so people could figure out what they needed to do and keep moving and didn't get kind of stuck in the process. I think that all helped with people sort of managing their workload.
Oh, thanks, Grace. Well, maybe again, Jacob, thanks for the question, and I'll pass it back to Ariana to wrap up. Oh, sorry, one thing, just my acknowledgement slide. Thank you so much. I obviously had the opportunity to come on here and yap to everyone today, but this was like a huge group effort. Like all the feedback was incorporated into the presentation, so it was a huge lift for everyone. Thanks, Ariana.
Thanks so much, Leslie, and just huge thank you to you and your team for putting this together. As always, I'm learning something, and it's great to be a part of. Well, thank you to everyone for joining. We have a post-session survey linked in the chat if you are able to take just a few minutes to fill that out. And then our next webinar will be on March 9th from 12 to 1 p.m. Mountain, and that'll be on applying burn ICU expertise to large-scale emergency preparedness. So with that, I think we can wrap it up. Thank you everyone for attending. And again, huge thank you to Leslie for speaking today. Really appreciate your time and your expertise. All right, thanks all. Bye.